Right? Right now it's bone. You can freeze for me. Good fun. So this is bone because you see very dark, right? Because the outline of the spinous process. Everything inside you cannot see. Agree? So now if you put this in the middle center of the screen, this will be the midline. So I scan and I put a mark on the skin. So you see one level, I come down, bone, no bone, bone again. Agree? So now you have two levels. You know where the midline is, midpoint is. You have one axis. Two dots form a line. So this is the midline. Or you can even go up higher, right? This is bone. Agree? Dark, bone. Bone. So you have three levels. You make a mark, this is the midline. So in an obese subject, can you freeze for me now? Freeze, partner. All you're going to see is bone, but not here. It will be here. This is all soft tissue. The dark shadow is over here. But you still can mark. Oops. So you still can mark the level as midline. So that's number one. Very helpful. Two. So this is a transverse scan. Now this is bone. Again, you cannot see inside. But now once you go between bone, less bone, less bone, less bone, less bone, and now beautiful. Can you freeze? So this will be the interlaminar space, in the spinous space between the spinous processes. I can see through it now, right? I will put a mark here on each side. Then I have a horizontal line. So I have a vertical line, horizontal line, the intersection. I put the back of the needle, put a skin marking, clean everything, prep, and then do a spinal and epidural. What do we see here? We see this is posterior, right? So this will be the posterior dura. This will be the anterior dura, posterior longitudinal ligament, and the vertebral body is here. This will be the subregular space, the dark area. Here I cannot really see the ligamentum flavum. I expect it to be somewhere over there, but I don't see it.
Maybe on the right side? On the right side?
Huh? What the bright line is the dura. You do not see the ligamentum flavum well because I borrow your hand. Do this for me. The ligamentum flavum is like that. The epidural space is triangular. So when you are scanning like this, he's not going to take it. Right? If you angle on the side and paramedian, you are more likely to see the ligamentum flavum. But if you are doing it like this, it's less likely you see it. But if you see it, it will be above this bright line. That's when you see it. Right, so let's finish the horizontal, then we look at the vertical. So in obese subjects, you will not see those beautiful lines. Okay, so all you're going to see is bone No bone. You won't see the lines inside. Bone, deep bony lines, and then no bone. That's all you're going to see. You will not see such beautiful structures inside. But even if you don't see it, if you see no bone, there got to be a space. There got to be a space in between. So all you need to do is form that axis and then go in. Now, so this is transverse to determine the midline and the interspinal space. Another way to scan is vertical, longitudinal. And what you want is you want to angle slightly inward, medially, and you will get inside the interlaminar space. So here, what you're seeing, those are the laminas. And you see a very bright line there. That will be the posterior dura. The posterior dura is about 4 centimeters deep. Angling a little bit inside is about 5.5, 6 centimeters. That will be the anterior complex. Do you see what I see? Okay. So now, if you do not see the posterior dura, right? I mean you see the anterior part. That's good enough. Meaning there got to be a window for the beam to go through. Right? If the beam does not go through, you would not see the anterior part. Right? Likewise, if I see the line like this, I know there got to be a window. Otherwise, you're not going to see through. I'm just going up again. You see both the anterior and posterior part now. Agree? So
on the right side. On the right of the screen, the two lines.
The two lines in the center.
Yeah, now in the center.
And sometimes you don't get the perfect view that both lines you can see well. And now this one is very nice. You can see both. Right? So freeze, please. In elderly subject, you may only see that much. Maybe only up to about there. Very tiny. Even that much window. Even that, if you see it, you can get it.
Paramedian. Paramedian would direct to the median.
With paramedian approach, usually in playing technique.
Can you see the...
You have this view, so you can do epidural with paramedian approach.
Well, again, doing it real time is very difficult.
If you have difficult epidural, because here you can see the posterior dura. So usually the paramedian approach.
Yes, our median approach is always bigger. The space is always bigger. So I always like to now do paramedian approach.
Because the catheter is...
You mean for the puncture?
Yeah, for the puncture, whenever I have difficulty, I go paramedian. And it's bigger.
Difficult to see the tip of the needle.
I know you're all asking about the ligamentum flavum, and if you believe me, if you freeze it, I would call posterior dura here. I was saying this is the epidural space. Suggests to me that the ligamentum flavum is about this level.
The ligamentum flavum, as we know, it's just near it's a potential space, the epidural space. So it's just near. We may not differentiate from it.
You may not, I agree. But you also may, because it has fat, right?
Yeah.
Fat, lymphatic vessels. So you're right.
And it's about 5 to 7 millimeters.
So
Epidural space down here in the lumbar.
usually there is, because if you do CT and MRI, you can see the epidural space. Usually it's triangular. So this is what you do. You can see the midline, you can see the interlaminar space, and finally you can count the level. You can count the level if you see a long line like this. That's the sacrum. Right in the center, the bony structure, that will be the L5 lamina. This will be L4 lamina. This will be L3 lamina. This will be L2. So L2, 3 is beautiful, perfect. Put it in the center again. You can put the line there. This will be L2, 3, 4. L2, 3 space. So that's how you tell. You press this here. So this is a more accurate way to count it. In elderly patients, you may be surprised. One side may not be as good as the other side. You can look at both sides. This is the left side. This is the right side. So you can check. So find a space that is biggest. Left and right side, find a space that is biggest. So that's how I do it. And then I mark. So I don't do real-time spinal because it's very challenging. If you do real-time spinal, what I do is I have the patient lying on the side. Do you mind lying on the side? So I usually do an in-plane technique. I find the interlaminar space. I usually tilt the probe slightly this side, so I tilt like something like this, because my needle is going in.
So which procedure now?
Huh?
Which procedure you're doing now?
Well, if you have to do an in-plane spinal, real time, then I put the needle here, where you can see the movement. And then I'm aiming, you see the lines, right? So the real advantage of a real-time spinal is if you can freeze it. The real-time spinal, the advantage is if you know how to do when I hit bone, for example. If I hit bone, I can see the movement is here. Then obviously I have to move the needle more carefully. If I see the movement, the needle is here, and I still hit bone, that means I'm too lateral. I then move the needle more medial to go in. So it depends on where I see the needle hitting bone. If I see it hitting there, I know I'm obviously not calculating enough, right? But if I see the needle movement is here, which is supposed to be the plane that I should get in, the space, and I don't get in, I hit bone continuously, I need to move the needle medial because it's hitting the facet. So that's what helps me. But otherwise, doing it real time is very challenging. Constantly struggling. So it's not easy.
Landmarks for the lumbar plexus.
So for lumbar plexus, again I have the subject curved up a bit. That's good. Leg up a bit. So I try to do it at L3, 4 level. So let's say I'm doing it with the operative side up. I want to look for the transverse process. This is lamina, agreed, because I can see inside the dura. I'm going more laterally. That will be the facets, in between facets, and now transverse processes.
You can play with that. So maybe it's one way of processing. We're like absolutely we are able to do that. But the knee replacement
So you freeze it.
provide pain-free surgery.
So these are the
So actually, it's femoral catheter.
transverse process. This bone, shadow, bone,
Spinal, and then the sciatic plug. We discussed the sciatic plug.
bone shadow, in between bone, muscle, that's the psoas muscle. So that's the this
Do
is
the spinal at
the set.
then after you do your femoral catheter.
So this is the upper one is easier to see.
Spinal reverse at 12 or 1 o'clock.
Do you appreciate the transverse processes?
You have your femoral catheter
You freeze it now.
and the patient is still completely
So again,
very pain. We need a sciatic. We do the sciatic at
one transverse process,
we run for
1 second
14 or 15
transverse
hours.
process,
We kill
This
the
will be
hyperurgency of the recovery time. So
paraspinal
we
muscle.
have a patient around pain-free up to 6 or 7 or 8 o'clock in the morning, and the pain will come back.
Now, if you increase the depth,
So I think for
so
me,
let's now look
management that all of us here are very much to do.
increase.
If you want to be tasked,
That's good.
you do that,
Increase a bit more.
you do triple punch. But you will see one day,
So now you see transverse processes. You also see the movement that is deep. That will be the peritoneal cavity. So you know the thickness of the psoas muscle. Agree? The thickness is probably up to about 9 to 10 centimeter deep.
that's the gold standard.
And if you go further, it will go into the peritoneum. So it helps you to define, if you freeze it.
More than, I think, 2,000.
So it helps you to define
Finished, but I have,
the
never
depth
I had
of the
5
transverse process.
I put one
The transverse process, you should hit it about 4.5,
can happen.
4 centimeter.
One catheter in the
It defines the thickness
nucleus.
of the psoas muscle,
Very nice.
and
also.
once you pass here, about 10 centimeter, you get into
The
the
spinal
peritoneum.
canal.
You also know you can choose the midpoint. You
But
can
I
then
never had an
put the
incident
needle
because I
in
was
between the two transverse processes.
I never did
You
a
can use
single
the
injection.
local hydrodissection in order to tell, and you definitely want to
It's a
use
risky
nerve
catheter.
stimulation to
It's a
guide.
phenomenal catheter in terms of analgesia.
Oftentimes, if I don't get, if my needle is already above posterior 2/3 of the muscle, I don't any twitch, I will go
I have three types of image. You have the
I will, up to you, I can do it like this, put the needle in, out of plane, and I have a better sense, but otherwise, do it, mark it, just like the epidural is good too. I don't think you need to.
inside the two cheeks.
Transverse approach, I think in her may not be too
Sometimes it
difficult.
goes in the
Right?
parallel
You see the
sometimes it goes posterior.
spinous process,
It goes all the time.
you see
Most
the
efficient
lamina,
because you have a phenomenal analgesia.
so usually you have to do a
The
little bit
sciatic
of
range
bleed.
of the L4, the anastomos, L4. So you have the L4.
So possible, it's so possible.
This would be the transverse process.
Sorry. Biopacification, refluroscopy.
Midline, so you
But
know
I'm not doing
we can see
I'm
the
not doing
transverse process.
all my hip replacement, were under biopress.
Just need a little bit more.
Fabulous. No,
So the next thing is look for
if
the
you know how to do this,
transverse process.
but I think we have to start with more than 100 blocks like that. Then after when you manage with this block, you will do 90% of your needs in regional anesthesia in the lower.
So that is your transverse process.
Then after, when you
And if I now slide down a little bit, the transverse process is gone, and all you're going to see is the psoas muscle. Now it's all psoas muscle here. Okay? If I go up, that is the transverse process blocking the view. Agree? Now bone is gone, all it is going to be psoas. And you can now put the needle lateral to medial. Some people would put it medial to lateral. So the advantage of medial to lateral is you're pointing away from the foramen. Lateral to medial, potentially you can go into the foramen.
What is safest approach? Transverse or safest approach for lumbar?
Safer approach for lumbar, whether it is this way or that way.
Transverse or longitudinal
Is it transverse or longitudinal?
I like this way, it's easier for me. This is longitudinal, but some people can use this approach. So again, that is transverse process. No transverse process. Do you see the muscle all group out? That's the psoas muscle.
No, there is one here.
And if you go deeper, and if you point the probe this way, sometimes you will see the right side, you can see the IVC. So do you see that vessel there? That's the IVC.
For this or not?
So that is the vertebral body. That would be IVC. Because I'm angling the probe this way.
For this?
So on the right side, is it
Right side is
artery?
IVC, left side will be aorta. But because you're standing oblique, you can see in front. In front of the
So there you're aiming now to the plexus or any spinal axis. This is very lateral now, right?
now what you're seeing is what you want to see is the psoas muscle.
Yeah, for what reason? What is the intention to see the psoas muscle?
Psoas compartment block.
Compartment. Okay.
Lumbar plexus. Okay. Questions? I think we need to go over these.